It starts with a bite. Sometimes you don't even notice it. But weeks later, your skin develops a rash. Your joints ache. Your thoughts feel slow. Your energy vanishes. Very quickly, symptoms can spiral into something a lot more serious. And this tiny bite from a tiny tick speaks to some huge problems with our healthcare system, like inequality in the distribution of treatment and diagnosis, and the speed at which misinformation can destroy public trust in the scientific method. In this episode, we're talking about Lyme disease, and we'll be speaking to two experts on the matter. Dr. John Aucott, director of the Johns Hopkins Lyme Disease Clinical Research Center, and Dr. Richard Marconi, professor of microbiology and immunology at Virginia Commonwealth University. This is your brain on Lyme disease. So, Dean, Lyme disease is an incredibly interesting topic. I say that often for every disease, but this one is important because it has many touch points. It touches on a disease that we're learning more about, but it also is almost a meeting point of multiple different social, economic, psychological, cultural and historical inefficiencies of our healthcare system and as human beings in general. There are even racial inequalities that come into foray. There's lack of access in healthcare for people who suffer from this disease. There's vaccine skepticism involved in this. And of course, the progress that we've made to learn more about this disease.
It's a perfect symbol of how one disease can actually affect so many different systems, especially a disease that is very unusual in its character. Its diagnosis is difficult, its symptoms are difficult. Often people don't really know much about it. In that uncertainty, what's created is incredible amount of distrust, incredible amount of chaos, and that's where we actually can learn about our healthcare system properly by looking at a disease like this. And why we need to address this in a much broader way is because in that gap, there's a lot of people that actually suffer, a lot of people that don't get care, a lot of people that are ignored, a lot of people that actually the medical system disregards and puts down. How often have we heard patients say that my doctor said that it's all in your head? And this is where proper language, proper conversation around scientific methodology has to come in. Not from a top-down perspective, from a broader conversation that society must have, but around one language, which is a scientific method.
Beautiful. I think this is a good point to actually go ahead and define the disease before we can introduce our speakers.
Absolutely.
So, definition. So, Lyme disease is a multi-system disease, and that basically means that multiple different parts of your body and systems of the body are involved, and it's caused by a bacteria called Borrelia burgdorferi. It's a mouthful, but I think it's been hammered in our brains during medical school and especially in the neurology residency program, and it's transmitted to humans through a bite by a tick. It's commonly known as deer tick, and it's the most common vector-borne illness in the United States and especially in the Northern Hemisphere. So what happens is after a tick bite, the bacteria, Borrelia burgdorferi, enters the bloodstream and it starts spreading everywhere. And early on, it causes a localized infection. It actually causes a rash, and that rash is called erythema migrans.
A very unique rash, because every test we took during medical school and even thereafter, there was a picture of that target sign, and that's unique to this infection.
It's burnt in our minds. So that's basically the very characteristic rash. Sometimes it's not there. Sometimes it doesn't even look like an erythema migrans, but you usually get a rash and then a localized infection. And that infection, if it's treated right away, that's it. That's the treatment of Lyme disease, and people don't tend to have chronic issues. However, if this continues to go on for a long period of time, the disease can become chronic.
Now, what's interesting is for those that are not treated or even not treated well, about 10 to 15% of them become neuroborreliosis. And that means that they have these neurological symptoms such as headaches, fatigue, fogginess, as well as radiculopathy, which is these sharp pains going down the arm or the legs. This is a fairly common disease, isn't it?
Yeah, it has to do with how sneaky this bacteria is. It really knows how to save itself. It actually morphs, and what happens is it starts creating this biofilm or a protective covering made out of protein around it, and it becomes almost invisible to the immune system. So it evades it, and it lives in systems where we don't have very active immune systems, such as the central nervous system, and sometimes it can actually live in muscles and tissues and joints as well. And so living in the brain, it can cause all the neurological symptoms that you described. And it's just fascinating that it starts almost acting like a parasite where it just pops up ahead and it becomes active when the immune system is on the lower side, and it continues to replicate and replicate. And that's why people have months and years of chronic issues with Lyme disease. But like you said earlier, the symptoms can be so vague, and it can be just brushed off as being tired all the time or having some aches and pain related to arthritis, but it actually may be Lyme. The numbers are scary. Statistics in epidemiology. The CDC estimated that nearly 500,000 Americans are diagnosed and treated with Lyme disease every year. That's 500,000 people every single year experiencing Lyme disease.
And that's the number that is diagnosed. A huge number are not diagnosed.
Absolutely. They go unnoticed. And it's endemic in northeastern, mid-Atlantic, and in the upper Midwest areas of the U.S. But now, because of the rising temperatures and because of the urban sprawl, which means people starting to live more in the forests and in nature, this is becoming more and more prominent. They usually thrive in warm and humid areas. And because people are living in those areas, we're seeing more and more of these cases.
And you see that how this actually is an intersection between environmental issues, socioeconomic issues, and then access issues. The fact that this is growing beyond Northeast, now pretty much throughout the United States, it makes it much more ubiquitous and present. And that's important because we don't have the kind of information in general public to acknowledge the ubiquity and presence of this disease throughout the country. And the information is actually dispersed even less in certain communities. In fact, ironically, the communities that are most at risk for these diseases are the ones that have least knowledge about it. And by the way, it's now growing not just in the United States, but throughout the world.
Yes, the numbers are rising in Canada and in Europe, and it coincides with milder winters, hotter weathers, and encroachment in the woodland areas as well. It truly is becoming more and more of an issue.
Absolutely. And so we have to address it much more systematically and make sure that the first point of public health, which is access to information, becomes universal.
And that is why this conversation matters.
Absolutely.
To talk more about the short-term and longer-term impacts of Lyme disease, we welcome Dr. John Aucott to the podcast. He's the director of the Johns Hopkins Lyme Disease Clinical Research Center. John's work has helped shape how we understand the post-treatment symptoms of Lyme disease that linger long after the bacteria are gone. His insights bring some much-needed clarity and empathy to the conversation.
So let's start with defining what is Lyme disease and why do we see a change or increase in prevalence of it?
So Lyme disease is an infectious disease. It's caused by a bacteria, Borrelia burgdorferi, and it's what we call a vector-borne disease. So it's transmitted by a tick vector from what's called a reservoir host where it lives, which are mostly small animals like mice and birds. It has to live in a reservoir host. It doesn't live in the environment on surfaces or the air or in food. It has to live in a host, and it's transmit from host to host by a tick bite. When humans are out in areas with ticks, we get bitten, and that's the way we get inoculated by the bacteria. It's distinct from typical bacterial cellulitis in that it's always round and red because it's spreading out from that inoculation site. People love to put the pictures of the classic target lesion bullseye, like the site of a Target department store. That's only about 20% of the lesions, actually. The majority are uniformly red. Sometimes they're darker red in the middle. And this actually leads to a lot of misdiagnosis because people are looking for the classic ring within a ring target. And often it's not. It's always round and red, but sometimes it's just uniformly red. But it is an enlarging lesion, so it's not small. It enlarges on average of a centimeter a day. So by the time it's diagnosed, it's typically greater than 5 centimeters. And they can get quite big. I've seen them a foot or two across because when it's not treated, it just keeps enlarging until the immune response finally gets it under control. So only 30% of people that we see with active Lyme disease recall a tick bite. Remember, the ticks are adapted to feed very quietly, right? They don't want you to know they're there, so they numb up your skin, they anticoagulate your blood. They do a lot of things to go undetected. So only 30% of people recall the tick bite that gave them Lyme disease.
The co-evolution of organisms is always fascinating. When I was in medical school in East Coast, and I remember the areas that were endemic for this infection and that you could find were pretty narrow. Geography has changed. It has grown, hasn't it?
Yeah, so this is a great study in the change of ecology in North America over the last century. In the agricultural phase of the continent, all the forests were cut down. There was almost no virgin forest left. It was clear-cut agricultural land, and that's not a great habitat for mice and ticks. You need three things for Lyme disease to flourish. You need ticks, the vector, you need the reservoir host, the mice, and then you need deer because deer are the main food source for the ticks. They're not a reservoir for Borrelia burgdorferi, but they're a food source for the ticks. So all those things had pretty much disappeared 100 years ago. But then sometime in the 50s and 60s, we started to reconvert that agricultural land back into low density housing. People actually re-imported deer for the hunters in different areas, and the deer populations expanded. People started living on 1 to 5 acre lots, which is the perfect ecologic niche to support deer, ticks, and mice. So we've recreated the perfect ecology to promote the proliferation of Lyme disease.
So we had a little bit of a hand in resurgence of this infection. But then we need the deer and we need the environmental changes that go with that. Absolutely. The other controversial issue is testing. There seems to be some question or a misunderstanding of how to test for this disease and Lyme disease in general.
Testing is very confusing. There are no direct tests for Borrelia burgdorferi. As an infectious disease person, I love to have a culture or a PCR to directly identify the presence of the active bacterial infection. It's like if you had COVID, you get a PCR test, and if it's positive, you have COVID virus on the swab. Those don't exist for Lyme disease. Standard tests are antibody tests. The problem with an antibody test is that's not testing for the presence of the infection. That's testing for your immune system memory of having encountered the infection. And that encounter could have been 10 or 20 years ago or 2 or 3 weeks ago. They could be false positives because they represent old remote infection that we recovered from. The flip side, there's also a lot of false negatives early in infection because since it's an antibody test, it relies on your immune system to make antibodies. We don't recommend doing an antibody test if you have the rash because that rash is present in the first few weeks and your antibodies will still be negative. So you're going to get a false negative test if you test at the time of the early rash.
Yeah. And add to all this the confusion that's coming to us from all these alternative diagnoses and treatments. As I was saying in another talk, whenever the disease has any room for uncertainty. Uncertainty is a feature of science. It's not a bug. It's a beauty of science. It's a systematic way of aligning yourself and correcting that. As it happens, for some reason, in today's world, they think that science has to be about absolutes. It's never been and it will never be. It's an iterative process. But in that lack of absoluteness creates a market of all these quacks and grifters that are taking advantage of people. And I've actually had many of my patients that came to me and said they've paid thousands of dollars for these alternative, not even treatments, alternative diagnoses because the original diagnosis was not certain. How would you speak to those individuals?
So I would start by saying that I'm very sympathetic to the individuals. We can all know if it was our loved one, we would do anything to find a diagnosis and treatment, right? And I'll defend the patients because they're often told because of that uncertainty that there's nothing wrong with them, that it's all in their head or that it's psychosomatic. The majority of those types of treatments aren't subject to FDA approval. They're often marketed as food supplements or alternative therapies that don't have to undergo scrutiny for effectiveness by the FDA. Supplements included. And so there's no data for me as a doctor to counsel patients on whether those things are effective. I am concerned when things are potentially dangerous. Always a potential for even natural products like herbals and things to be dangerous, right? Just because something's natural or an herbal doesn't mean it's not chemically or biologically active, right? Mushrooms are one of the most dangerous things in the world if you eat the wrong one.
Absolutely. No, and your approach and starting at that point is so refreshing. The patient is not at fault. There's already a divide between clinicians and patients, and this sense of putting guilt and blame on the patient is absolutely wrong. So I appreciate that greatly. As far as treatments, the standard treatments for this disease is doxy and ceftriaxone and things of that nature, right? Has anything changed as far as treatment is concerned?
Before we do that, we probably should define a couple things. When we talk about treatment, it depends what aspect of Lyme disease we're treating. And in my world, Lyme disease falls into two big camps. There's active untreated Borrelia burgdorferi infection causing manifestations of Lyme disease. And those, like syphilis, occur in stages, early, disseminated, and late. So it depends what stage you're treating, but they're all treated with antibiotics because it's an active Borrelia burgdorferi infection. That's very different than the much more controversial treatment of what, and here terminology is a big thing, is often in the lay public called chronic Lyme disease. In the research world, we define it more precisely and narrowly for research purposes. We call it post-treatment Lyme disease because those people have already been treated with antibiotics and the majority of them don't need more antibiotics. They have what is now sometimes being called an infection-associated chronic illness, very similar in many ways to long COVID or chronic fatigue syndrome. It's an illness that's triggered by infection, but the infection may have left and be gone, and yet the person's left with this chronic illness. And that's treated very differently because it's not necessarily or usually a chronic bacterial infection. It's an infection triggered illness that may have many different causes. And that's actually our area of research is what causes these chronic symptoms that we call post-treatment Lyme disease, very much like long COVID or chronic fatigue syndrome. Treatments are very different than treating active Borrelia burgdorferi infection. It's controversial because it's by nature defined by the patient's symptoms and history of exposure to the Lyme disease, but the Lyme disease could have been 5, 10 years ago. They may have long forgotten about it, or they may have never really had a clear diagnosis because of the vagaries of testing. It's less controversial in my mind since COVID because long COVID, I think, has a little more acceptance. So post-treatment Lyme disease is still primarily a clinical diagnosis, but it's got diagnostic criteria. The Infectious Disease Society of America issued criteria in 2006, and it's basically based on a physician-documented case of Lyme disease, like somebody with the rash. They get treated with antibiotics, and the rash goes away, the objective findings go away, but they're left with the classic symptoms of fatigue, brain fog, and pain, which are very similar to long COVID. And I've seen hundreds of cases where I diagnose the rash because we do studies and enroll people with rashes, and they end up with post-treatment Lyme disease 6 months to a year later. We've published on this. The rate varies between 10 and 20%. And that's interesting. That's about the rate, maybe what long COVID is. It's about the rate of chronic fatigue after mono, right? So there's something interesting going on about these certain infections. Not all infections, but some infections have this propensity to trigger a host response that results in a chronic illness. And the phenotype is very similar: fatigue, brain fog, and pain.
This accounts for 10 to 20% of population that have depression. Having taken account depression and anxiety and all those things, it still is distinctly a diagnosis in itself.
So we control for depression in our studies. In our prospective study, we actually exclude anyone with a prior history of significant depression. So we did all that and controlled for it. That's one. Two, though, I will push back a little bit and say, this is a neurologic disease. What causes depression? Neuroinflammation, potentially. So there's a big study from Europe where people that were admitted for major Lyme disease had much higher rates of subsequent depression.
Absolutely.
We see that all the time.
Amazing. And any treatments in the horizon potentially? Has anything worked in this population?
Well, it depends which mechanism you think
Yeah.
is at work. If it's dysautonomia, yeah, there's tons of treatment for POTS and dysautonomia. If it's autoimmunity, we have one investigator that's studying overt triggered autoimmune arthritis after Lyme disease. People that get Lyme disease and then have a new autoimmune arthritis months to years later, and then you treat them like they have an autoimmune disease with biologic inhibitors
Mhm.
because the Lyme disease, in our opinion, is triggered an illness that looks like rheumatoid arthritis. And so, again, you're not treating Borrelia burgdorferi, you're treating an autoimmune disease. We treat those people if they have evidence of autoimmune arthritis the way you would treat autoimmune arthritis, the way a rheumatologist treats autoimmune arthritis. Occasionally, we find people that weren't adequately treated with antibiotics initially. Maybe they had neurologic disease that wasn't recognized and didn't get adequate treatment. So
Mhm.
I'm an infectious disease person. Sometimes I'll retreat the people with a defined course of antibiotics. So it depends what the underlying mechanism. We don't think it's a uniform population. We think this is a heterogeneous population. Some of the people are going to have dysautonomia, some autoimmunity, some
Mhm.
bacterially driven illness. And so that's why we still get to be good doctors, right? You got
Yeah.
to figure out what's going on.
Yeah, no, absolutely. And the few patients that I have, this chronic fatigue component, how do you address that?
Well, it can be from dysautonomia, right? So if you
Yeah.
have POTS and you're not delivering blood to your brain, you're tired, right? So we treat the POTS and dysautonomia if it's present. Again, this is all off label. Remember, there's no FDA approved treatment for these illnesses. So everything I'm telling you is off label, right?
Yeah.
So you can use off label stuff that's used in fatigue with MS. So we use modafinil and things like that. So we use off label drugs that have been on label for other illnesses. We use SNRIs for people if appropriate, and those are on label for fibromyalgia, for instance. Modafinil treating POTS, cognitive behavioral therapy. We actually have a trial right now that's just entering the data analysis phase using psilocybin therapy. It's all in the investigational arena right now.
That's amazing. And it is exciting because it's unknown, but when it's done in the right setting with the right way of looking at the data, it's going to give us insight, not just into this disease, but other comorbidities as well. Yeah, absolutely. So this podcast is Your Brain On. So I would love to ask, how does Lyme affect your brain?
Yeah. So again, I'm going to use this dual diagnosis paradigm. So untreated Lyme disease, active Borrelia burgdorferi infection. We talked about how the inoculation is in the skin, the bacteria proliferate. When not treated with antibiotics, the rash goes away, but about half those people, the Borrelia burgdorferi is disseminated from the skin to distant organs, half or more. And the most common site it disseminates to is other areas of the skin or the joints. That's how Lyme disease was discovered from late Lyme arthritis. But actually, in the early disseminating phase, maybe 10 to 15%, it disseminates to the nervous system. So there's your brain and peripheral nervous system involvement. It occurs typically 4 to 12 weeks after the tick bite. It goes primarily to several areas, the meninges, so you can get
Mhm.
Borrelia burgdorferi meningitis. It looks like an aseptic meningitis. It can go to the radicular nerves and cause radiculitis. That's hard to diagnose. It looks like shingles without a rash and it gets misdiagnosed all the time for sciatica or appendicitis. It just depends what dermatome's involved. And then occasionally the peripheral nerves themselves. And then the other big one are cranial nerves. And by far the biggest cranial nerve is the seventh nerve,
Seventh
facial
nerve, yeah.
palsy. But I've seen every possible cranial nerve involved. If you have the classic triad of cranial neuritis, radiculitis, and meningitis, that's called Banworth syndrome. And that
Yeah.
was actually described in Europe over 100 years ago. Europe has more neurologic disease because Borrelia guerini, a different species that's only present in Europe, not America. Borrelia guerini tends to cause more neurologic disease. So they have more neurologic disease in Europe than we do. But we have neurologic disease, primarily facial palsy, some meningitis, and then radiculitis.
Amazing. Now, as far as the brain fog and cognitive symptomology, slowness, memory, focus, in those patients, what's the correlation?
So here, most of the people, remember the brain fog is more of a symptom of the post-treatment Lyme disease. So when I'm evaluating someone with brain fog, it's not usually in the context of acute meningitis, right?
Yeah.
Or acute facial palsy of untreated Borrelia burgdorferi infection. It's in the context of previously treated Borrelia burgdorferi, and now they have post-treatment Lyme disease.
Yeah.
Those people you rarely rarely find evidence of central nervous system infection. They don't have a CSF pleocytosis usually. Occasionally, they'll have an elevated protein and a few white cells, but it doesn't look like aseptic meningitis. They don't have encephalitis on traditional MRI scans. So it doesn't fit the paradigm of encephalitis or active meningitis. There's the paradigm of inflammatory mediators crossing the blood-brain barrier that can cause these kind of symptoms. If post-treatment Lyme disease has a peripheral systemic inflammatory component, whether we can measure it reliably yet or not, that can cross the blood-brain barrier and cause brain fog and symptoms. And then the area I'm really excited about is our work done with Sherry Marvel here at Johns Hopkins, looking at brain imaging, not with regular MRIs don't show anything, but functional MRI and PET imaging shows actually surprising changes, again, in these people with post-treatment Lyme disease. And that shows that these people have glial cell inflammation. This is not active Lyme infection. This is post-treatment Lyme disease syndrome. So they don't have normal brains. They have positive PET scans on TSPO PET imaging. So again, it points to the fact that these people with brain fog, they're not psychosomatic. They're not making it up. There's a physiology going on here. We just haven't figured it out yet. How to treat it, it's not clear yet, how to treat the brain fog. Again, if it's due to autonomic dysfunction, we treat the autonomic dysfunction. If it's due to coexisting or triggered depression, we'll use SNRIs sometimes. It's all off label. There's no FDA approved treatment for it. We use cognitive behavioral therapy too.
Yeah. And I would be interested to know what FDG PETs and glucose utilization data show us.
Yeah, so they're not, you can't order them clinically because they're
No.
not reimbursed. And so you get us a grant and we'll do it.
Okay, fantastic. We'll work on that together. Yeah. And as far as long-term sequela, there's this, I don't want to label it yet, but there's a thought out there that if once you have Lyme, you'll always have Lyme and Lyme disease. What's your take on that?
That's because some people end up with post-treatment Lyme disease. And that it can, not always, but can be a chronic illness. So I think that's where the misinterpretation comes in. It's not that you always have active Borrelia burgdorferi bacteria living in your tissue and proliferating. That's not thought to occur after adequate antibiotic treatment. But the 10 to 15% that get post-treatment Lyme disease, that is a chronic illness. I see people that have been ill for 20 plus years now with this, and it's not typically a terminal or lethal illness, but it has a dramatic impact on health-related quality of life in some people. I've taken care of kids that had to drop out of college, that had their entire lives derailed. Some people slowly get better. Some people slowly get worse. Many just wax and wane. And we do our best to try to treat their symptoms and identify one of these causes like dysautonomia that we've talked about and treat that. But in a referral population, at least, it's a chronic illness.
Yeah. Yeah. And then as far as research, where do you see the excitement? Where is the most exciting research being done?
It's at Hopkins, of course, but
of course. I will tell you, the Mayo people were saying Mayo, so
that's right. That's right. And they got an organism named after him, Borrelia mayonii, so I have to give them that. I think there's two areas of excitement. One is AI. We have a National Science Foundation funded grant right now looking at using AI to diagnose the rash off of cell phone images. I get cell phone images texted to me all day, right? Because everybody wants to know, is this Lyme disease? And HIPAA out the window, they text me the pictures of their rash, right?
Yeah.
And so I got the idea, let's let AI make the diagnosis. So that works. And we have a grant right now to develop algorithms for AI diagnosis of the rash. We need a biomarker for, especially for the chronic Lyme disease. And then I'm also big on imaging. Imaging revolutionized the diagnosis of MS. MS used to be called the faker's disease, right? And then all of a sudden you get MRI and they're not faking it. There's other things I'm sure coming down the road of ways to put objective parameters around what's right now or just patient reported symptoms of brain fog. We've got to get objective measurements. Docs need objective measurements both to diagnose and to follow treatment. And so I think imaging and biomarkers are going to be huge in the next few years.
Our thanks to Dr. Aucott for sharing his expertise. One of the striking things for me was when Dr. Aucott compared the PTLDS, post-treatment Lyme disease syndrome, and long COVID or chronic fatigue syndrome, the similarities between them. And this is what makes Lyme disease so frustrating, and we've actually seen it in our patients. Now, part of what makes Lyme disease so frustrating is it's created this perfect storm because it's misunderstood, and you have so many patients who have long-term symptoms of Lyme disease, and they're most often ignored by healthcare systems. Hopefully not in the future. Since we didn't really have any resources and we didn't know much about the disease, we usually just brushed it off and we didn't want to deal with something as chronic as Lyme disease. When that happens, people naturally start looking for help somewhere else, and that's where a lot of these alternative medicine clinics come in. They will run some tests that are not based on evidence, that haven't been validated, and they're given the label of chronic Lyme, which, to be clear, hasn't really been registered and accepted by a lot of the medical associations. Then they recommend all sorts of different treatments, whether it's IV medication or concoction of vitamins or detoxes or some herbal supplements, etc. Most of these are not backed by evidence. They're not part of the guideline-directed therapies, and they're extremely expensive too. And you and I have seen our patients actually even experience some of the side effects of these treatments too.
Absolutely. These charlatans, they thrive on people's hope. And the gap between suffering and uncertainty, this is a painful thing to see because the patient is suffering and they've gone from doctor to doctor. And most doctors, when it's not clear to them, they basically disregard the patient. That's at best. At worst, they actually say things like it's in your head and you're imagining things and really hurtful concepts. So they run to the first person that tells them, oh, it's not.
I got you.
Yeah, I got you. I will find the solution. As if there's always a solution to everything.
They feel seen and heard. I want to make sure that I don't paint everyone with the same brush. There are a lot of compassionate individuals in that field. There are people who truly care about helping others and making a difference in their lives. But the problem is that this kind of unregulated care often takes advantage of people's fears and frustrations, as you were saying earlier. It really damages them physically, emotionally, and financially.
The reality is sometimes the patient actually feels better because whenever you're seen, whenever you're acknowledged, whenever you're getting a treatment, you're going to feel better for a short period of time. And now you're invested in the person and in the fact that you invested in this concept. And later when the symptoms come back and they're feeling worse, they never acknowledge that change, or they don't go back and say that the treatment didn't work. And therein lies a big problem, that once a person is lost to the medical system, to the scientific system, they're in the grasp of a very nefarious and destructive system that is difficult to escape. It's from one person that gives them one group of alternative medications to another. Now they're going down a cycle because the first time they felt good. And we see this so often.
Absolutely. We have to acknowledge that there is a public trust issue, and we also have to know that this mistrust is often built on real experiences that people have gone through, and it's up to the rest of us in the medical community to rebuild that trust with better communication, better research. I think communication probably is the most important thing here. How we speak with others, how we inform others, how we feel comfortable with not knowing the answers to everything.
Correct.
And conveying that in a compassionate way to our patients.
There's a lot of people in certain aspects of lifestyle or functional medicine where they have an answer to everything. Whenever somebody has an answer to everything, they're not to be trusted. The nature of science is that at this point, there are things that we don't know, and a physician should be able to tell the patient that we don't know, and do it in a way where you actually still have the trust of the patient and you convince them of the data. So that's an opportunity.
Yeah.
I think one of the most important things, and I've said this in many podcasts, one of the most important things that us as scientists, us as doctors, us as leaders in any field, one of the most important jobs we have is to communicate the scientific method, reason-based process.
Absolutely.
That way you're not taking sides. There are no sides. You have to assume that everybody has goodwill, and often they do. Don't take sides. Just teach the community, teach others, and teach yourself how to communicate the scientific methodology. And the fact that scientific methodology has an imperfect and often incomplete and often a very systematic way that might seem unsatisfactory, but that's reliable. And it's a language that we can all speak and we can work around, as opposed to somebody who says, don't trust anybody. I said this because I have 5 patients that had responded to this. I think that this disease, as well as post-COVID and others, which have this amorphous nature to them, is an opportunity for the medical field to jump in, bring the patients that are suffering from this, and all of us together learn the language of the uncertainty of disease, going through the process of treating the disease, and also dealing with symptoms that are not treatable. Lyme disease, especially chronic Lyme, and certain other diseases, sometimes you have to live with certain symptoms long term, but you have to gain the trust of the patient to make sure that they understand that is something they have to live with.
Beautiful. This brings us to our second guest, Dr. Richard Marconi, a professor of microbiology and immunology at Virginia Commonwealth University, and one of the scientists trying to solve a problem that shouldn't still exist: why we don't have a Lyme vaccine for humans. He unpacks what happened the last time we had a Lyme disease vaccine for humans, what's coming next, and how we can rebuild public trust at such a volatile time for science.
I wanted to start by asking you the common vector for this, and have the cases increased in the last few years and decades?
Sure. I began working on Lyme disease as a postdoctoral fellow at Rocky Mountain Laboratories, which is the National Institutes of Health lab, back in 1990. And at that time, Lyme was really something that we were aware of and concerned about, mostly in the Northeast, the upper Midwest, and to some degree along the West Coast, and of course in Europe as well. The number of cases have gone up dramatically, which is consistent with the dramatic increase in the tick population, not only in tick density within a given area, but also we're finding Ixodes ticks in places where they really weren't commonly encountered just a couple of decades ago. There's also better recognition, which has led to improved detection of cases. So the CDC back in 1990 was reporting somewhere around 25,000 cases per year, but subsequent studies show that the compliance with reporting was actually very low, less than 10% in most cases. We see this in companion animals as well, which are sentinels for Lyme disease. So particularly in our dogs, where we actually have better epidemiological data for companion animals than we do for humans. And that's partly because in companion animals, such as our dogs, those dogs that reside in endemic areas are routinely tested each year for a variety of tick-borne diseases. And we know that there's approximately 600,000 to 700,000 positive antibody tests in companion animals each year alone.
That's very interesting. So do we have numbers as far as the percentage of individuals that are infected from deer-born versus from pets?
So we don't think there's a significant transmission from our pets to ourselves. The numbers for Lyme disease really come from exposure in the wild, so to speak, or in our yards. Now, certainly our dogs can bring ticks into the house, but typically, as soon as ticks attach to a mammal, they are rapidly going to seek out a blood meal. So they don't spend a lot of time walking around on our pets, so to speak. So they get onto our dogs and they will start feeding very quickly. And an important thing to know about the vectors of Lyme disease is that they only take a single blood meal during each developmental stage. So that becomes relevant because if your dog comes into your house and it has ticks on it, those ticks are probably already feeding. Once those ticks have fed, they're going to drop off and undergo a molting process. But conditions within the home are not conducive to molting and to the subsequent further development of ticks. Not impossible to get it from your dogs, but it's just not a major player in the scenario.
Absolutely. As far as vaccination, Lyme vaccine for humans, LYMErix was pulled from the market in 2002, despite showing 76% effectiveness. Can you tell us about what happened there?
Sure. There's a lot of misunderstanding about LYMErix and why it was pulled from the market. LYMErix entered the market in 1998. We were all quite excited about it at the time and thought it was going to solve the Lyme disease problem. And as you mentioned, it was a 3-dose series in year 1 that yielded about 76% efficacy. But shortly after the vaccine was introduced, there were some reports anecdotally that it might be causing some significant adverse rheumatological events and arthritis and et cetera, things like that. A full analysis showed that was not the case. There was really no evidence to support that. It was essentially withdrawn from the market by its manufacturer really due to declining sales. And not only declining sales, but also class action lawsuits that were being filed by a variety of groups contesting that the vaccine was responsible for some serious adverse events. So several things combined that resulted in it simply not being economically feasible for the supplier or the manufacturer to keep it on the market. But having said that, it was also a vaccine that required 3 doses in year 1 and frequent boosters thereafter. The booster schedule had not yet really been fully defined as to what was needed to provide protection year after year. And that vaccine was basically a protein derived from the Lyme spirochetes called outer surface protein A, or OSPA, as we call it. One of the reasons why the LYMErix vaccine and OSPA vaccines in general require frequent booster vaccinations is because the OSPA protein is actually not made by the Lyme disease spirochetes when they enter into a mammal. It's only made when those bacteria are living inside of a tick. So the way that the vaccine worked is that if you had sufficient levels of circulating antibodies in your blood, when the tick takes a blood meal on an immunized person, those antibodies go with the blood into the tick. And if the antibody titers are high enough, they could prevent the spirochetes from transmitting into the mammal. But unfortunately, any spirochetes that do successfully transmit into the human or the mammal, once they get into the mammal, they can't be touched by the antibodies to OSPA, because the bacteria don't have any OSPA on their surface. All those things really came together and accounted for the quote-unquote demise of LYMErix. There are several vaccines that are being worked on right now. So I'll start by talking about the ones that are most advanced in terms of clinical trials. There's a company called Valneva who was working on a Lyme disease vaccine, who partnered with Pfizer several years ago. They are developing an OSPA-based vaccine that, in terms of the way that it works, is very similar to the LYMErix vaccine. What they've done that's different from LYMErix, and there are, of course, many subtle differences, but they've increased the number of variants of the OSPA protein that are included in the vaccine. And the reason that they did that is because they wanted to be able to use this vaccine in Europe and other parts of the world. So as it turns out, in North America, we generally have really just one variant of OSPA that shows up in the Lyme disease spirochetes. But in Europe and Asia, you have other additional variants as well. So the working hypothesis behind this other vaccine, which is referred to as the VLA15 vaccine, is that by increasing representation of different OSPC proteins in the vaccine, they could get broader protective coverage and have a vaccine that would be applicable for use both in North America and Europe as well. But nothing has really changed, though, in terms of the way that the vaccine works, which some would argue, and I would be in this camp, that's a limitation of the vaccine. Mostly because of the development of vaccine hesitancy and just the fact that a vaccine that requires 3 doses in a year, at least in the first year, and multiple boosts thereafter, is one that generally doesn't go over very well with the public.
That makes sense, absolutely, especially in lieu of the vaccine hesitancy that you pointed to. What about the other vaccines?
So we're working on a vaccine that's very different from an OSPA-based vaccine. To briefly summarize what's different about the approach that we're taking is that, first, we developed a vaccine called Lyme that's widely used in veterinary medicine. Lyme differs from any of the human vaccines that have been used in that it consists of 2 recombinant proteins, which again just means proteins that are produced in the laboratory. And it has an OSPA component to it, but it also has a second protein that is based on a protein that's made by the Lyme disease spirochetes when they're actively infecting a mammal. And that protein is called outer surface protein C, or OSPC. So OSPC is a really important protein for the Lyme disease spirochetes because they must be able to produce it in order to transmit from a tick into a mammal, and they must be able to produce it to successfully infect and persist in a mammal. The problem that was encountered many years ago with using OSPC as a vaccine candidate is that the OSPC protein is really remarkably variable. What we did is we identified the immunologically important parts of the OSPC protein, so very specific segments of it, and we assembled them together to create first a new piece of DNA or a new gene that is not an OSPC gene. It's a new piece of DNA that encodes a protein that has multiple segments and many different OSCs assembled together. And we call that a chimeritope. It stands for chimeric epitope-based protein. Chimeric is when we join things together. Epitopes are the immunologically important parts of proteins, and that's what we join together to make the OSC chimeritope. We've since modified the vaccine formulation to adapt it for humans. And mostly what we've done is we've changed the OSP-A component. Our new human vaccine, which we intend for use in humans, contains two proteins. One is an OSP-C chimeritope. The other is a chimeritope based upon epitopes from a couple of different proteins. And where we think it holds an advantage is that this type of vaccine formulation can elicit antibodies that can kill the bacteria both in the tick as well as in the mammal. And it's also, because of its design, it's able to elicit memory immune responses that can provide for longer term protection.
Amazing. So what are your hopes about vaccination? And let's take the political climate that we're in as well. What do you think that the possibilities are in the next few years?
Obviously, things are quite interesting right now in terms of the political climate and the views of some about vaccines. I still remain quite optimistic. There is a need for a Lyme disease vaccine. And earlier we were talking about the fact that when LYMErix came onto the market was perceived to be fairly small. We know that the incidence of Lyme disease is increasing quite dramatically. One of the unique things about Lyme disease is that everybody knows about it. Right? When you talk about Lyme disease, people, they've heard of that before. You're not talking about some abstract virus or something that they may not be familiar with. It's also an interesting disease because it's one that's associated with healthy activities. When are you likely to get Lyme? Gardening in your yard, hiking in the woods. People are aware of Lyme disease. They want to be protected against it. I think that the market will be quite receptive to a human vaccine. Whereas if you went back to the demise of LYMErix, when that occurred, there was basically a shutdown in big pharma on working on new vaccine formulations, which is really quite tragic because I think had the effort been kept up at that time, we would have in place right now one or more effective vaccines for Lyme disease. Now people are back at it, and hopefully more than one vaccine. It's always good to have options.
Appreciate that. Lastly, what I always ask scientists is what excites you about the future of this research?
A lot of things, really. First, the bacteria that cause Lyme disease are just so remarkably unique that they're fascinating to study. I could talk for a long period of time about what's so unique about them, but from a biological perspective, they're just remarkably interesting organisms. The interplay between ticks and these bacteria and wildlife and human populations is really quite fascinating. But one of the things that excites me the most is what our ultimate goal is. We're working very diligently on a human vaccine for Lyme, but we also want to be able to develop a vaccine that will protect against other tick-borne diseases as well. So I think what excites me is the possibility of developing combination vaccines that can protect against the major tick-borne diseases, which in my mind would be Lyme disease, anaplasmosis, ehrlichiosis, and potentially babesiosis down the road as well. A vaccine for anaplasmosis or ehrlichiosis probably won't be successful on its own, but delivered in the context of a combination vaccine, I think there is a lot of potential there, and I think we can accomplish that down the road.
We're so grateful to Dr. Marconi for giving us such an optimistic outlook. I'd like to present a summary of what we learned. So now we understand that Lyme disease can have serious consequences, but there's a lot we can do to prevent it. And there are some steps, they sound easy, and it should become a part and parcel of our lives, especially for those of us who live close to woodland areas or hikers like you and I. They should be very careful about these things. But the unfortunate thing is it's now actually showing itself in suburban areas as well. So everybody should know about these things. The first one is avoid high-risk areas. Thankfully, in every hiking area or a forest area, there are some signs, and health authorities can actually identify places that have a lot of tick, and people should just be aware of that and read it. Do you read signs when you hike, Dean?
I do. I love it because some of them are pretty interesting.
They are. They're very interesting. Second thing is using insect repellents, and these are in the form of creams or sprays that you can spray on your clothes or on your skin. The third one is wearing light-colored and long-sleeved and long pants. Just cover your skin. I think it's the most reasonable thing to do. Some of the things that we've learned is how to tuck in your pants inside your socks and make sure that you have buttons around your wrists so that it's tight and your skin is not exposed. And especially for parts of your skin that you don't see, like the back of your knees or your hairline and things of that nature, where ticks mostly stick to. The fourth one is doing a full body check. Have a loved one or a friend check your back, behind your ears, around the hairline, behind your knees, and then showering within an hour or two of hiking or going outdoors to make sure that you get rid of any ticks that may be lingering somewhere. And there have been actually studies show that it reduces the risk of Lyme infection significantly. What happens if there is a tick on someone's body? It should be removed quickly and it should be removed properly. We now actually have these tick kits. Difficult to say tick kit, but it comes with a tiny little tweezer. It has a little container, and I even saw a small little magnifying glass in one of them, which was adorable. But these kits are available for everyone to have in their pocket, in their backpack when they're going hiking. And you basically remove the tick very carefully with the tweezer, and there's instructions in that kit of how to do so. It's always advised to put it in that container or in a Ziploc bag so you can show it to your healthcare provider as soon as possible. And of course, the foremost thing you do is get yourself to a doctor so that they can start treating you. Look out for rash, look out for symptoms, and get it treated as soon as possible. Now, the greater tragedy of Lyme disease is in its symbolism. It's a case study in how misinformation, systemic inequality, climate change, scientific mistrust, they all converge at one point, and it's destroying public trust. Patients who don't really fit neatly into this little box are usually ignored, and they suffer for a very long time not knowing what's going on. So I think we all have a responsibility, whether we're in the healthcare system, whether we're in public health, whether we are just individuals who are aware of the spread of misinformation or aware of how science moves forward, for all of us to come together and address it as best as we can. We've been your hosts, Drs. Aisha and Dean Sherzai. Thank you so much for listening. We hope you enjoyed this episode. If you're listening to this podcast on Apple, please make sure that you subscribe and give us a review. That's the only way that we can spread this information to everyone. We appreciate you.